Okay, good afternoon. So today's topic is examination of sinus and fistula. First you must know the basic thing about how to examine sinus and fistula. Some theoretical knowledge should be there. So what is sinus? A sinus is a blind track leading from the surface down to the tissue. So it is a blind track. From the surface means any skin surface, it goes inside into the depth of the tissue. There may be a cavity inside the tissue or there may not be any cavity, sometimes there may be cavity, and this sinus tract, it is lined by granulation tissue and subsequently it may be epithelialized. And in case of fistula, this is not only tract, it is a communicating tract. So, fistula is a communicating tract between two epithelial surfaces. If the communication is between skin, that is external surface, with some hollow viscous, then it is called external fistula. And in case of communicating tract between two hollow viscous, two hollow viscera, then it will be called internal fistula. So, fistula may be external or fistula may be internal. And here also this fistula's tract is lined with granulation tissue and it also subsequently it can be epithelialized. Sometimes you will get patient of sinus or fistula for long time which is not healing. So, persistently there is sinus or there is persistent fistula. Now, let us discuss what are the causes for this. So, causes of persistence of sinus. There may be a foreign body, so presence of foreign body inside the sinus tract. For example, any suture material, non-absorbable suture material is there. That is why the sinus is not healing. Persistently it is there, or there may be some necrotic tissue inside the tract in the depth. For example, sequestrum. What is the sequestrum? Sequestrum is, it is a dead bone. It occurs in case of osteomyelitis, that is the inflammation of bone. In that case, dead bone is there. So, if there is dead bone inside the tract, so there will be persistence of the sinus. Some sinuses are at such places where there is absence of rest. This sinus is not getting rest, so healing is disrupted. That is why there is persistence of sinus. Another cause may be there is a non-dependent drainage of the abscess. Abscess is drained in the upper part, it is not dependent. So, non-dependent drainage. So, abscess passes cannot come out. So, that is why there is persistence, or there may be inadequate drainage of abscess. In that case also there may be persistence of sinus. In some cases the sinus is because of some specific chronic infection. In that case also sinus will be persistent. For example, tuberculous sinus. Tuberculous sinus, unless and until you give the specific treatment of tuberculosis, then this sinus will persist. Another is actinomycosis. Here also specific treatment is required. So, in those cases sinus may be persistent. And another thing is this tract, if the tract is epithelialized. Epithelialized means there is some new skin formation around the inside the tract line. So, in that case the tract will not collapse and there will be persistence of sinus. Another cause is there is dense fibrosis around the tract or the any cavity. If there is dense fibrosis, so that fibrosis prevents the collapse of the tract. So, that is why the tract is not healing there is persistence of sinus. Now, what are the causes of persistence of fistula? Fistula, actually, if it is a true fistula seldom heals. Once the fistula has formed, because the fistula, they have got constant discharge like urine, if it is a urinary fistula, feces, fecal fistula, biliary fistula, bile. So, persistently these discharges are coming out, that is why true fistula seldom heals. If the natural passage is patent, then his fistula automatically heals. Now, in case of sinus fistula, you take the history. From the history part, first is some sinuses are present since birth, from the very young age, since birth. For example, is preauricular sinus. Here is this is the place where preauricular sinus occurs, and you will, if the patient gives, sir, this sinus, this disease is already there since birth. So, your diagnosis is automatically preauricular sinus. Then history of in case of osteomyelitis sinus, you will get some history of high fever, pain and swelling of bone, and there will be history of discharge of bone chips, some pieces of bone, dead bone coming out. If you get such type of history, your diagnosis is osteomyelitis sinus. There may be this sinus persists due to the sequestrum. I have already mentioned sequestrum is a necrotic, it is a dead bone inside the sinus. So, if you get the history, some dead bone is coming out, so your diagnosis is automatically osteomyelitis sinus. If you get some history of tuberculosis, so tuberculosis history like history of lymph node enlargement, bone TB or joint TB like cold abscess, if you get this type of history, so your diagnosis is it is a tubercular sinus. The perianal sinus or perianal fistula, you will get some history of perianal abscess or ischiorectal abscess. Patient will give, yes sir, there was abscess, whether it is operated or not, or whether it is spontaneously burst. So, you may get the history of abscess. So, your diagnosis is this is a perianal sinus or it may be perianal fistula. Fistula, when it is fistula, you will see the external orifice, if it is communicated with the rectum or anal canal. So, it will be a fistula. If there is no communication, it is a blind tract, then it is a perianal sinus. Then if you get some history of pain in case of sinus or fistula, pain means there is some inflammation is there and there is blockage of the opening of sinus or fistula. When there is the opening, external opening is blocked, so all the things are accumulated inside the tract. So, patient, because of this pressure, the patient will complain of pain. Then if the history gives fever, redness of surrounding skin, that is the sinus or fistula is of inflammatory origin. Okay. Now, you take the first history. Past history, you may get past history of tuberculosis or any Crohn's disease, ulcerative colitis, actinomycosis. So, this type of sinus or fistula, it has come with past history of this. So, think of these diseases are persisting. Then, if you see one anal fistula, do not forget to take the history of any colloid carcinoma of the rectum. So, if you do not examine the rectum or anal canal, you may miss the carcinoma of the rectum. So, in case of colloid carcinoma of rectum, patient may present as anal fistula. Then there may be past history of any operation history. So, this present sinus or fistula may be a complication of that past operation. Then you take the history of family history. In family history, you may get somebody is suffering from tuberculosis, Crohn's disease, ulcerative colitis, because these diseases run in the family. So, if you get some family history, positive family history of these diseases, so think of these diseases in your patient also. Another is fistula in ano. The fistula in ano also runs in family. Then we will come to the examination part, examination of sinus and fistula. First is the local examination. At present, I cannot show you any patient here. So, I am talking about the how to examine the sinus and fistula. First is the inspection. You see the number of sinus or fistula. Mostly fistulae are single, you will get single fistula, but multiple fistula you may get in, if you get some multiple fistulae. So, think of watering can perineum. Watering can perineum is there is multiple fistulae, it occurs in case of periurethral infection, periurethral abscess formation, like that. Then in case of Crohn's disease, which affecting rectum and anal canal, in that case also you may get multiple fistulae. Another, this is the ulcerative colitis. Ulcerative colitis also may produce multiple fistulae. Actinomycosis always produce multiple sinuses, not fistulae, sinuses. So, if you get a multiple fistulae in a patient, you must think of these diseases like Crohn's disease, ulcerative disease, these things. Now, next is the, where is the position of the sinus or fistula in the body, because with some position, on looking the position of the sinus or fistula, you will automatically diagnose the patient. This one condition I already told, that is preauricular sinus. Preauricular sinus, your history is this since birth. So, it is why it is occurs? It is due to the failure of fusion of ear tubercles. Can you remember those embryology classes? Yes, that ear tubercles, some fusion is missing. So, subsequently it forms the preauricular sinus. It what is the site of this sinus? It is at the root of the helix or on the tragus of the pinna. So, if you get one sinus at the root of the helix or tragus of the pinna, patient is giving, it is present since birth. So, your diagnosis is over. Another congenital condition, that is the branchial fistula. Branchial fistula, due to failure of fusion of second and fifth branchial arch. Again you remember those embryology class. So, second and fifth branchial arch fusion is missing. So, that is the result of branchial fistula. If you see the site, it occurs at the lower third of the neck in front of sternomastoid muscle. Okay. So, looking at the site, your diagnosis is okay. Next is the pilonidal sinus. You will mostly get in the back side in the midline position behind the anus. So, if you get one sinus just behind the anus in the midline or back, so think of pilonidal sinus. Then actinomycosis. Actinomycosis, I have already told, actinomycosis always produce multiple sinuses. Where is the site position? It is multiple indurated sinuses at the upper neck. So, if you get some multiple indurated sinus at the upper neck, think of actinomycosis. Tubercular sinus is peculiar in position because tubercular sinus starts from the lymph nodes. So, where there is lymph node, tubercular sinus can occur at that place. You know the common sites of neck glands, axillary glands, then inguinal glands. These are the sites for tubercular sinus. A single sinus over the lower irregular jaw, that is the mandible. If you get one single sinus and you feel this mandible is irregular, indurated, say this is actually osteomyelitis of the mandible. So, this is a osteomyelitis sinus. Now, you see the opening of the sinus. If you see there is sprouting granulation tissue. Granulation tissue is coming out through the external orifice. So, think of presence of some foreign body inside at the depth. What kind of foreign body? It may be a sequestrum, that is dead bone. There may be drainage tube inside, or there may be a bullet inside, or there may be suture material inside the depth. And if you see the opening of the tubercular sinus is like, it is wide and this the margin is very thin, blue and undermined. In your that is ulcer class, you got this type of undermined edge like that. So, tubercular sinus is like that. Then you observe the discharge from the sinus or fistula and notice the character. This is a type of discharge. What type of discharge? In case of osteomyelitis, you will get pus, frank pus, and in case of tubercular sinus, you will get very thin fluid, that is called serosanguinous fluid. So, if you get a very thin fluid is coming through from one sinus, think of tuberculosis. And in actinomycosis, sulfur granules are coming out, that is a yellow color, sulfur granules are coming out. And in case of fistulae, what type of discharge you expect? It may be urine, urinary fistula, it may be feces, that is the fecal fistula, and it may be bile, that is the biliary fistula. Now, you observe the surrounding skin, if you see any scar formation or not. So, in case of chronic osteomyelitis, in case of healed tubercular sinus, you will get scar around at the surrounding skin. Then, if you see dermatitis and pigmentation around the surrounding skin, think of Crohn's disease, actinomycosis, etc. Now, next part is, now inspection is over. Now, next part is you will have to palpate the thing. First, you see palpate for any tenderness or not. Is the sinus tender or not? All the inflammatory sinuses, for example, osteomyelitis, these will be tender on touch. Okay. Now, you feel the wall of the sinus, whether it is thickening is there or not. In case of chronic sinus and there is fibrosis around the wall of the sinus, you will get thickening around the wall of the sinus. So, you can feel it. Then you see the mobility. Mobility, is the sinus mobile over deep structures? Now, you palpate for mobility of the sinus. Is the sinus mobile over deep structures? Any sinus of osteomyelitic origin, it will be fixed to the bone, and you see the bone is you can feel it is irregular, thickened and tender also. Now, feel for any lump inside. So, lump in the neighborhood of the sinus you may find in case of tuberculous lymphadenitis. Okay. So, this is the palpation is over. Next is special examination in case of sinus and fistula, that is called examination with a probe. Through probe you examine. Probe, it is a metallic instrument. So, through the probe you will get some idea about the direction of the sinus and also the depth of the sinus. So, this examination must be done very carefully because it may be very painful. Usually we examine this probe test examination with the probe in some anesthetic with the help of some anesthesia, so that patient does not get much pain. So, in examination with probe you will get the information about the presence of any foreign body, for example sequestrum, whether it is mobile inside the depth of the sinus, whether the fistula is communicated with hollow viscous or not. So, that with the help of probe you will get that information. And again whether the fresh discharge is coming out on withdrawal of the probe. When you do the probe test, on withdrawal of the probe some fresh discharge may come out, and notice the type of discharge, whether it is pus or it may be blood or it may be serous fluid. And no examination of sinus and fistula is complete without examining the draining lymph node sites. You know the lymph nodes, all the lymph nodes should be examined, particularly according to the site of the sinus or fistula. Then lastly you go for some general examination according to the site or according to your cause of sinus. Examination of the particular system must be done. Suppose there is a sinus in the loin, sinus in the loin. So, you see the spine, definitely spine should be examined, ribs should be examined and kidney should be examined, because there may be some abscess formation in the perispinal region, for example cold abscess that is coming through the tract and forming a sinus in the loin. So, you do not know. So, similarly rib and kidney abscess formation, that may lead to sinus formation in the loin region. Then any sinus, whether it is due to chronic empyema. So, you must examine the chest, that is respiratory system. Then sinus due to osteomyelitis according to site. So, examine the bone according to the examination of the diseases of bone, that will be a separate class for you, examination of diseases of bone. So, in that case you will get the details about this examination. Then if you get fistula around the anus, perianal fistula, you must examine the anal canal, rectum physically on finger test, that you must see through proctoscope, sigmoidoscope, even you may have to go for colonoscopy, and the whole abdomen should be examined in case of perianal. Why? Because I have already told perianal sinuses may be due to some associated diseases like Crohn's disease, okay, ulcerative colitis, like that. So, you will have to examine the whole patient as a whole. And now the multiple fistulae in perineum and scrotum, that is because of this periurethral pathology. So, you must examine the lower urinary tract. Then if the sinus fistula is present in the groin region, so definitely you must examine the hip joint. There may be pathology in the hip joint, that is why the sinus has formed. Then there may be pathology in the spine, that is for example cold abscess, like that. So, you must examine the general examination like this. Okay? Thank you.